Hello and welcome. Good evening to our friends in Asia. We are back again with another month of educational webinars for you. This is the first talk in the month of May, and we have two very wonderful lectures lined up for today. The speaker for the first session is Professor Kazuhiko Kurozomi. Professor Kurozomi is a professor and chairman in Department of Neurosurgery, Hamamatsu University School of Medicine, Shizuoka, Japan. He is a prominent member of the Japanese Society of Neurosurgery as well as member of the Japan Society of Gene Therapy, Japan Society of Skull-Based Surgery and Neuroendoscopy. He was honored with several grants and awards for his illustrious career, namely in the Journal of Gene Medicine, Japan Society of Gene Therapy, Investigator Award, American Society of Gene Therapy Travel Award, and Japan Society of Neuro-Oncology Hoshino Award. He is a prominent author and has published several manuscripts in various peer-reviewed journals. We are extremely honored and thankful to Professor Kurozomi for accepting our invitation for speaking to us at our webinars. Today he is going to talk about gene therapy in neurosurgery. The second speaker is our honored guest from Japan, Professor Takashi Izumi. Professor Izumi is the professor of neurosurgery and interventional radiology at the Nagoya University School of Medicine, Nagoya, Japan. He is a prominent member of the Japanese Neurosurgical Society and is also an acclaimed author who has published several manuscripts in various internationally peer-reviewed journals. We are extremely honored and thankful to Professor Takashi Izumi for accepting our invitation to be a speaker at our webinars. Today he is going to talk about diagnosis and treatment of dural AV fistula. The chair for the first session of our webinar is Professor Jianhong Zhu. Professor Jianhong Zhu is the professor of neurosurgery at the Fudan University Huashan Hospital and deputy director of National Key Laboratory for Medical Neurobiology. Dr. Zhu is one of the expertise in neural stem cell research. He led the first team to successfully grow human neural stem cells from open brain trauma in laboratory and used this to repair the damaged brains of head injury victims in Fudan University Huashan Hospital. He received the Young Neurosurgeon Award of the WFNS. He served on the executive committee as a treasurer of Asia-Australia Society of Neurological Surgery and the vice president of the Chinese Society of Neuro-Oncology, the vice president of Shanghai Neuroscience Society, and an editorial board, Regenerative Medicine in UK. We are extremely thankful to Professor Su for accepting our invitation to chair the first session of our webinars. The chair for the second session of today is our honored guest from India, Professor Anil Karapurkar. Professor Karapurkar is the professor of endovascular neurosurgery at the Breach Candy Hospital, Mumbai, India. He is the senior most faculty of endovascular intervention in India. He was the past president of the Asia-Australasian Federation of Intervention Neuroradiology. He has also been on the advisory board of the World Federation of Intervention Neuroradiology. We are extremely thankful to Professor Karapurkar for accepting our invitation to chair today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers and chairs to this online platform of educational webinars. Dr. Liu Boon Seng from Malaysia is my co-host for today. And with that introduction, I would like to hand over this platform to Professor Jianhong Zhu.
Thank you. Thank you to introduction. Good evening, everybody. I'm Jianhong Zhu from Shanghai. Now we're beginning the first topic, gene therapy in the neurosurgery. The speaker will be Kazuhiko Kurozomi from the Hamamatsu University. Doctor, please beginning.
Okay, thank you, Chairman. I will share my slides. Thank you very much for giving me the opportunity to present my data. Today, I would like to talk about gene therapy, oncolytic viral therapy, and basic research in glioma. My name is Kazuhiko Kurozomi, a very difficult name, so please say Kazu. Kazu is easier. Nickname is Kazu. I'm no conflict of interest with any corporate organizations relating to this presentation. Today's topics, I would like to introducing myself and gene therapy, oncolytic viral therapy, and other my researches. Here is Japan. Hamamatsu is here in Shizuoka Prefecture, next to Nagoya, next to Yokohama. And my hometown is Okayama City. This is next to Hiroshima and Hyogo. I moved to Hamamatsu last year. This is Hamamatsu Medical University here. And I started the neurosurgeon in 1997 in Okayama University for residency. Then I have been to the Ohio State University. That's for 3 years. Then I came back to Japan. I was working at the Okayama University. Then last year, May 1st, in 2020, this is like anniversary today. So my publication is in JNCI or molecular therapy and so on. And I was that was introduced already. I'm being continuously funded Kaken grant. My interest areas are brain tumors, gene therapy, oncolytic virus therapy, molecular targeted drug, and of course, skull-based surgery, neuroendoscopic surgery, and pediatric surgery, and uro-oncology. So our Department of Neurosurgery, Hamad University School of Medicine, there are approximately 330 surgical cases per year. Brain tumor, vascular disease, Parkinson's disease, spine, and pain pediatrics. And for brain tumor therapy, there are several projects using a molecular target drug or gene therapy, oncolytic virus therapy. We are performing a cadaveric study and using a monitoring navigation and using an endoscope 4K, 8K system. Firstly, I want to show the neurosurgery stuffs, endoscopic and exoscopic surgeries for my introducing to improve the accuracy and safety of our endoscopic procedures. We are currently trialing 4K or 8K systems. These endoscopic things, video scope and endoscopes. This was full HD system. For example, this is a craniopharyngioma patient in the third ventricular area. This is a normal pituitary gland. And here is optic chiasm. This is a tumor. We are using navigation system, magnetic electromagnetic neural navigation system. I punctured this cyst, then removed this tumor upward. Then I took this tumor under the endoscope system. This was a little bit difficult case, but I could take tumor totally. This was post-operative MRI. And the other thing is, so this chordoma case, also, I don't have time, so I couldn't show you the video, but this is the post-operative image. Tumor was removed. Now we are using a 4K system, 55 inches monitors, Sony and Olympus system. And I've experienced for 8K system. It's a sharp monitor like this. So now I'm trying to use this exoscope system. This is a Vitomus, and we're using a navigation system. For example, this is medulloblastoma, fourth ventricular tumor. This is the storage system. I'll show the video. A little bit. So this is a operative video. So we are using 3D monitor. This is the full HD monitor. This is the exoscope Bitom. This is very comfortable for operator. So easy to do operation here. Tumor was removed here. Okay, so from now, I will show our research. We are doing the research for brain tumor, vascular disease, Parkinson's disease, PET study or MRI study, especially brain tumor, oncolytic virus, molecular target drug, invasive model, and gene and cell therapy, and genetic analysis. For the targeting brain tumor, malignant glioma. So this is a very bad tumor, as you know. Approximately 1 year dead. So today's main topic, gene therapy and oncolytic virus therapy. So gene therapy is this introduces new genes into a cancerous cell or the surrounding tissue to cause cell death. A wide range of genes and vectors are being used in clinical trials with successful outcomes. As you know, this is a schematic of approaches to gene therapy applicable to both gene editing and gene transfer. Like in vivo gene editing, we are using liposome, viral vector, polymers, peptides. And this is ex vivo gene editing. We are taking targeted cells and we put genes with a viral vector or non-viral delivery, like electroporation, ribosome, polymers. Then gene edited cells, we are expanding these cells. Then we do re-infusion these cells. This is the history of gene therapy around 1990. First human gene therapy with the retroviral vector for skilled ADA. For adenovirus vector, first human gene therapy for cystic fibrosis. Then, so RNAi was discovered here. But unfortunately, there is one serious complication in adenoviral vector like here. So a little bit stopped for in gene therapy. But there is a first approved oncolytic virus in China. And this from 2010, 2010, there are many gene therapy started, then restarted. First lentiviral gene therapy product licensed in Europe. And of course, CRISPR-Cas9 was found. This went to the Nobel Award. And the TVEC, this is oncolytic virus approval as a monotherapy for melanoma by the US Food and Drug Administration here. So this is a very popular therapy, I think. So this is also history, and 2016, oligonucleotide therapies and CAR T therapies, then AAV transgene, and gene editing started like this. So now for gene therapy, there are several methods of viral vector, gene editing, recently CAR T cell therapy. I have no time to talk about all things, all stuff. So then I'm gonna talk about viral vector. So there are several viral vectors: adeno-associated virus, adenovirus, retrovirus, or lentivirus, herpes virus. This has disadvantages or disadvantages. So allowable size of foreign DNA is this is small, this is larger. And targeted cells were non-dividing cells. For these two stuffs are dividing cells also. Integration into the genome is retrolentivirus. Duration of expression is long duration is AAV. Other virus are transient, and so on. So another thing is we need to learn suicide gene therapy also. There are two popular suicide gene therapies. One is TKGCV system, and another one is CD5FC system. So TKGCV is tyrosine kinase. This is a prodrug. We can put the TK tyrosine kinase into the retrovirus or adenovirus. Then that tyrosine kinase can gun cyclovirus to the phosphorylated gun cyclovir. Then this affect to the toxic metabolite then to the apoptosis. Another one is cytosine deaminase. So we can put this cytosine deaminase with adenovirus or retrovirus. Then this cytosine deaminase can convert 5FC to a 5FU. So then it could have apoptotic effect. So these are suicide gene therapy. This is adenovirus vectors clinical trials. Several ones are TK system. And another one is this is a P53 tumor suppressor genes. We can put those genes into the adenovirus. So this is, for example, so this is my project in Okayama University. This rake gene therapy. This rake is a reduced expression in mortal cells, DKK3. This is a tumor suppressor gene. It was found in Okayama University 2000. And firstly, we showed there is an anti-tumor effect if we put reg DKK3 to the tumor cells, because tumor cells are reduced in this rake gene or protein. This normal human society is more. So then we put this rake gene with adenovirus, and then we can have apoptotic effect. And another one is in Okayama University, they made a super gene expression system, adenovirus mediated reg DKK3. This is enhancer is different from prototype ones. Then we can show there's a significant prolonged survival than conventional types. Then we move to the clinical trial. This is the study protocol of our phase 1/2A clinical trial of ADSG for treatment of recurrent malignant glioma. I also made a protocol for this gene therapy. This is started. This started in 2019 May. This is this is a study protocol for phase 1/2A clinical trial. The primary endpoint is to assess the safety of ADSG injection into brain tumors in patients with recurrent malignant glioma. Secondary key object is efficacy. So this is performed in performing in Japan, open label, single center. Then this is ongoing clinical trial. We are waiting for this result. Next is genes and cell therapy. So this also I don't have enough time, so then just talk about a little bit. Cell-based delivery. Before as I talked, putting a cells, putting a gene to the cells. For example, we are taking blood cells, then we put therapeutic genes here, and then cultures. Then we put to the body again. So there are several cells which we are using. Recently very famous stuff is CAR T cells therapy. But we are also focusing on stem cells, neural stem cells, mesenchymal stem cells, ES or iPS new cells. Then we are ongoing basic research for those cells. Okay, next one is oncolytic virus therapy. Oncolytic virus can replicate in your tumor cells, not normal cells. So then, oncolytic virus can infect in tumor cells. Then there's a lytic cycle here, and after that, tumor cell debris or tumor-associated antigens induce the dendritic cells, and it can activate naive T cells or attract and activate innate immune cells. Then tumor cell death. Very interesting treatment. Oncolytic virus therapy also, there are several oncolytic viruses. HPV, adenovirus, HSV1, vaccinia virus, virus, measles virus. And there are several mechanisms, oncolysis, and this is target to the endothelial cells or anti-immune activation, and it can have therapeutic gene expression also. This is adenovirus stuff. This A is wild type. Then this B is delete E1B is in Onyx 015 adenoviral vector, very famous ones. E1B gene is deleted, and it can replicate conditionally. This is also a conditionally replicated adenovirus. This is delta 24 BP indicates 24 base pairs deletion in the RB binding domain of the E1A gene. And this one is this E1 region and E3 region deleted. Then we can put therapeutic genes E3 region here. And this is replication incompetent by the particle, so not to replicate this DNA, this virus. So this oncolytic virus therapy is like adenovirus stuffs, delta 24 RGD clinical trial completed, and other delta 24 stuffs also. And herpes viruses also are usually used for oncolytic virus. The G207 is a very famous one. This is insertion of E. coli laxi, sequencing ICP6. This is to reduce ribonucleotide reductase activity. And this is deleted gamma 34.5, and it to reduce neurovirulence. So like those herpes virus are very famous, HF10, and this is a TBEC. TBEC is now on clinic. So the clinical trial finished to the malignant melanoma. So we can use this TVEC for malignant melanoma, not glioma yet. This is a construct for those oncolytic virus. Those oncolytic virus ongoing clinical trial, HF10 and G07. And the interesting thing is RQ ones, which was made in my old boss in Ohio State University. This one is this RQ nestin 34.5 is engineered HSV based strain ones. And this rostry tumor selective viral replication in vivo experiments show that the survival after symptom onset of glioma bearing animals and was significantly prolonged after treatment with this virus compared to other controls. So this is now currently under investigation in a phase 1 clinical trial for recurrent glioblastoma in combination therapy with cyclophosphamide. This is performing, Dr. Kyoka is performing this study. And there's TBEC and G70 delta, G47 delta here. So this 47 delta is also famous now in Japan. This was the first described by Todo from Tokyo University in 2001. It is based on the D207 virus. This contains additional deletion in the region of the ICP47 gene, which eventually mitigates enhanced expression of MHC1 on virus-infected cells. This has been tested for safety efficacy in patients with recurrent progressive glioblastoma, and interim analysis of the phase 2 glioblastoma study in 2019 presented with encouraging data. 1 year survival rate of 92.3% compared to control. Very interesting oncolytic virus. So Todo is now preparing for using clinic. Then finally, I would like to talk about my research. So there are many researches. So then I showed a little bit data for each researches. For tumor microenvironment, for oncolytic virus therapy, and I made new virus previously, and this one like DKK3 stuff. I don't have time, so I can say that about this. And we are focusing on invasion of glioma, especially bevacizumab-induced invasion, and biomarker stuffs, and glioma stem cell and differentiate glioma cells on one. First one, I also using HSV1 derived virus. This can infectable to human cells. This has a large genome, and this is a relatively low multiplicity of infection, and it has antiviral drugs. And in Ohio State University, I was researching on the role of tumor microenvironment in OV therapy. This is, for example, we are using rat glioma syngeneic model. We implanted brain tumor here. Then 7 days later, we treated with intratumor injection, OV injection. This is the oncolytic health virus HR3. 3 days later, we injected fluorescence dyes with the tail vein injection to analysis vascular structure. This is my result. Very interesting things is this is the control lateral hemisphere here, and the control tumor area. There's a weakness and fuzziness in a tumor area. Instead, there's very hyperpermeability in oncolytic virus treatment. Very interesting interesting results. Then I hypothesized that pretreatment with anti-glioma drug could reduce or induce inflammatory response. Then we used anti-angiogenic drug that was a syringe site. So then get down the number of the vessels and the tumor inflammatory cells infiltration down, and viral propagation is up. Then I expected tumor regression. So we use integrin inhibitor syringe site previously. This could induce apoptosis integrin alpha V beta 3 or 5 expressed in the serial cells or glioma cells. This is a result. Day 10, it shows OB as weakness. Instead, OB plus lenstite, the vascular permeability was down. In cytokine genes also, there is so cytokine gene intratumor expression is decreased, and interferon gamma ELISA is get down the concentration in interferon gamma. Then contrary, HFC propagation was more occurred. Then we could have a prolonged survival here. So next thing is I made new virus with PhD student in Ohio State University. This was BAY. We use brain-specific angiogenic inhibitor 1 sequence, and then we use only this fragment. This fragment was named vasculostatin. This is the vasculostatin. So we put that vasculostatin to the this sequence area in oncolytic herpes virus. This vasculostatin was controlled by the IE45 promoter. This was called Rambo. So this Rambo would expressing a vasculostatin. Then this is a conventional one, and it shows this Rambo is prolonged survival. And also did Rambo plus flenistate integrin inhibitor. So there is prolonged survivors here. So this was Ohio State University, 2005 to 2008. Dr. Kyoka is a very famous chairman. Now is working at the Brigham Women's Hospital, and Barbin Carr is now in Texas, University of Texas. She became a full professor. The next stuff is we did this research in Okayama University for bevacizumab. It's a clinical trial has demonstrated convincing therapeutic benefits in glioblastoma patients. However, its induction of invasive proliferation has also been reported. Then we use the U87 delta EGFR tumor cells, the asthmatic rats and the asthmatic mice. We injected, we make a tumor model, then we injected the bevacizumab. Then check the immunohistochemistry, microarray, qPCR analysis. There's the anti-angiogenic effect of bevacizumab. This is untreated ones. This is treated ones. The vessels number is getting down with bevacizumab. But effect of bevacizumab induced tumor invasion like this one compared to the untreated ones. Then we tried to use integrin inhibitor, that was the selenstite. Since selenstite could suppress tumor invasion like this. Then we also did microRNA analysis. Then very interesting thing is integrin-mediated cell adhesion pathway has downregulated in this combination treatment. Other things for bevacizumab-induced glioma invasion, we checked for other project, we found delta catenin related to the this induced bevacizumab-induced glioma invasion, and also we did using Rambo, we can stop that invasion of bevacizumab. There is an invasive model of glioma, human glioma primary culture model, and bevacizumab. There is a little bit invasive effect here, but we can stop that invasion with Rambo. So very interesting data. So other stuff is I have no time for this one, so then I skip to 5. This is also very interesting things, but I'll skip this one. I'll show the final ones. Differentiated glioma cells accelerate tumor progression by shaping the tumor microenvironment. This is a very new paper. This year was in this year, this paper was published, and very interesting ones. So cellular components of glioblastoma microenvironment. Usually there are very glioblastoma stem cells is very famous now. And we are checking the differentiated glioma cells. Then we check the interaction for the microglia, immunocells, and blood vessels. So on. We did check the determination of transcription DGC signature for RNA sequence dataset. So each slide shows we can find we could find top 50 genes upregulated in DGCs, top 50 genes upregulated in GSCs, like this. So we found those gene signatures for these DGC and GSC. Next, as a next step, we also used the single cell RNA sequencing data like this. So very interesting thing is DGC signature and GSC signature. This is a converted correlation. And this is a GSC and DGC. So then we validated this transcriptome DGC signatures in larger cohorts of tumor with a TGCA glioblastoma dataset like this. Then if there's DGC high signature and DGC low signature, if we compare both, there's a significant difference of survival time. High DGC highs was very bad. We check the transcriptome DGC signatures correlated with immune responses. So DGC high glioblastoma patient ones and moderate ones. Then we put together the 24 genes pathways will come up. Then those pathways related with to the immune response and the inflammatory response related. And then in detail, we check that that in immune cell signature, especially macrophage signature, upregulated like this. Then that is related to the TED signatures. This specific transcription activation region was associated with this TED signature. TED associated also with the YAPTAs, very interesting ones.
Last 2 minutes.
Okay, last 2 minutes. Okay. Identification. Then the upstream of this YAPTAs is identification of CCN1. CCN1 is upstream ones. Then we found this CCN1 genes from human protein atlas ones. And CCN1 is operated in a DGC relative to GSC, differentiated glioma cells. Very interesting. Then if we put SH RNA with a DGC in a CCN1, then combination, then that prolonged survival. Okay, so the summary of our findings. So we found the interaction of GSC and DGC with macrophage and CCN1. For this conclusion, our result revealed that DGCs contribute GSC-dependent tumor progression by shaping a mesenchymal microenvironment via macrophage infiltration and provide a new insight into the complex GBM microenvironment consisting of heterogeneous mixed cells. Those are ongoing research for us. This is today's topic for me. So these acknowledgement, Okayama Universities and Ohio State Universities. And this is Okayama University's Dr. Professor Date. I'm thanking them. This is a new, my department, Hamamatsu University School of Medicine. Thank you very much for your attention. Thank you very much.
Thank you. Very nice talk. Very nice picture. And very nice progress in gene therapy research. Very impressive. May I ask some question?
Yeah, okay.
I heard about you propose some clinical trial use the adenovirus like DKK3.
Yeah.
When did you study this clinical trial?
That was 2019 May.
Wow.
But that is phase 1, 2A. Then now is continuously recruiting patients. Then, but now it's ongoing trial. Then I cannot talk about in detail. So, but yeah, good, I think.
Understand. Congratulations for the clinical trial.
Yeah, thank you very much.
You know, the treatment GBM is tough.
Mm-hmm.
May I ask about use the AAV gene therapy for muscle dystrophy? What do you think about?
So AAV is very so easy to use, and continuously that those genes are expressed. But for glioma, so we need longer code genes. Then it is hard to put those genes. So then we didn't use so much. Yeah, that is the problem, I think.
Novartis company launched by the FDA approved the gene therapy for muscle dystrophy. I think it's good for the neurological disease use gene methods.
Yeah, I think so. Yeah. So for neuro, so not cancer or for neurogenetic disease or Parkinson or other MS or something. So that is good for I think.
Yes, for the gene therapy research, a lot of the technique, recently the mRNA technique, especially by the Moderna and BioNTech for vaccine, but also can use for the, as the gene therapy the methods.
Yeah.
What do you think about?
Yeah, actually, so that is for making a vaccine for COVID-19. So mRNA technique is very important. But for cancer or glioma is especially glioma is it is hard to there is a problem that is BBB. So it is hard to put that mRNA or with IV injection or something. So we are still having a problem. So we need to overcome those stuffs, I think.
Thank you. Anyone have the question? Okay, if not, we finish the first topic. Move to the second one.
Yeah, thank you very much.
Thank you very much, Professor Jian Hongzhu. That was a very wonderful presentation from Professor Kazuhiko Gurusumi. With that, we'll move on to our next chair, Professor Anil Karapurkar, sir, who will say a short introduction and invite Professor Takashi Izumi.
Thank you, Professor Raja, and thank you, ACNS, for asking me to chair this session. Can you hear me? Can you hear me?
Yes, sir.
Yeah. Yes.
So thank you for asking me to chair this session, and thank you to ACNS also. Dural fistula is something that we knew very little about. I have been treating dural fistula since the 80s, and until 90s we had no clue as to how to treat. 80s, late 80s, 90s we started treating from the venous route. We used to occlude the transverse sinus, the sigmoid sinus, by coils, and slowly we have switched now to the arterial route. But today we know how to treat dural fistula, but I find that usually the diagnosis is missed for many months, for many years. So the average from first symptom to diagnosis is a few months to sometimes even few years. So let us see what Professor Takashi Izumi has to say about dural fistula today. Thank you very much, and we may maybe ask Professor Izumi to start his talk.
Thank you, Professor. Yes. Thank you so much. And today my topic is diagnosis and treatment of dural arteriovenous fistula. And I'm from Nagoya City, from Japan. Nagoya City is here, Japan island. And Nagoya is located between Tokyo and Osaka, or it's in center of Japan. And my today's content is here. And yeah, first is the principle of treatment for dry arteriovenous fistula in general. And second is case presentation and cavernous sinus duravex, suprasagittal sinus, and transverse sinus, and suprapetrotal sinus. And during this case presentation, I mentioned the image interpretation and the treatment strategy. Driver AVF is the shunt itself is located on the dura or in the bone. And second, caliber of feeders is smaller than drainers, neighbor shunted point. The third, Borden type 2 or 3 is an indication of invasive treatment. And the fourth, after all shunted pouches are embolized, shunt will disappear. And the first, the shunt itself is located on the dura or in the bone. If shunt is located on the brain or in the brain, the shunt is diagnosed as pyeloAVF or brain AVF. The shunt is located on the dura, so transvenous embolization can be cured without hemorrhage. Second, caliber of feeders is smaller than drainers. To read DSA or 3D DSA, caliber change is one of most important findings. It means the connection between arteries and the veins. Here's the cavernous sinus dural view, AP view, and the magnified view. And here is small, tiny feeders. And here is a larger pouch. Here is a venous side. And here is a caliber change. We can see caliber change, the connection between arteries and the vein. Sometimes shunted area form the pouch or accessory sinus, so-called parallel sinus. Here the shunted pouch, at least two shunted pouches were seen in this angiogram. And the third, Borden type 3 or 2 or 3 is an indication of invasive treatment. Retrograde left meningeal venous drainage can cause venous congestion of brain or cerebral hemorrhage. Here is the Borden classification. Type 1 means normal antegrade flow of left meningeal vein. And the type 2 means retrograde flow into the normal subarachnoid vein. Shunt flow into normal subarachnoid vein. Here is the reflux. Type 3 means isolated sinus or direct shunt. 20% of cases cause aggressive symptoms, hemorrhage or venous interruption. And the poor prognosis factor is the other poor prognosis factor is symptomatic, male, high age, with venous dilatation and posterior fossa. On the other hand, complication rate with IVR is 6%. And curative rate is Onyx TA is 72 to 95%, and MDTA is 33%. Only radiation therapy is about 2/3. Radiotherapy with TAE is up to 83%. So IVR is first choice in general. And the Borden classification is useful for assessment to natural history. Annual hemorrhage rate is different depending on Borden type. Borden type 1 is 0%, and 2 is 6%, and 3 is 10% annual hemorrhage rate. And Borden type 2 or 3 annual mortality rate is also high at 10%. So we must treat Borden type 2 or 3 dry AVF. And here's summary of natural history. Dry AVF, all dry AVF is not so high annual hemorrhage rate, 1.8%, but symptomatic dry AVF with retrograde RLVD, 80%. But without hemorrhage case, it means venous congestion cause neurological symptom is not so high hemorrhage rate, 1.5 to 10%. But with hemorrhage case, is need to early treatment because the hemorrhage rate within 2 months is 35%. Is very high. Ideal treatment is occlusion of all shunted area, but the shunted pouch is not always single. Multiple or diffuse shunt often needs extensive embolization. Here is a cavernous sinus dural AVF, 75-year-old female. She has parasitic tinnitus for 10 years. And incidentally, MR showed the cavernous sinus dural AVF, so she hoped the embolization. And the physical exam, conjunctival hyperemia in left eye was seen. In MRA, it showed the cavernous sinus is a high intensity area. And here the DSA, right ECG, AP view, and lateral view. And feeders, right ascendopharyngeal artery is the main feeders, and right MMA and right accessory meningeal artery and artery for rotundum, they gather into cavernous sinus here in lateral view, in AP view is here. Drainer, left IPS and left SMCV, superficial middle cerebral vein, and SPS was seen. Left IPS is used for TV as access route. Here the right ICH is lateral view. At first, this structure in arterial, early arterial phase. In this structure, same as here, like ECS structure. And here the left ECG, AP view, and lateral view. Feeders is almost the same name, and they gathered in intercavernous sinus, like right ECG. Drainage is same. Here's left ICG. Right ICG shows same structure in early arterial phase. Summary of DSA finding this cavernous sinus driver. Bilateral ECG shows the shunt well. Feeders gathered in intercavernous sinus. Feeders of bilateral ICA will contribute to same shunt pouches. Cortical vein reflux is seen. Left IPS is patent. Here the rotational angiogram of bilateral left ECA, and we did a bilateral ECA rotational angiogram to get the 3D information. Here the fusion angiogram of 3D DSA. Yellow it means the left ECA, and red is right ECA. Here's a very beautiful image, but I think this 3D image has less information than a source image. Here's source image, this 3D DSA, but this image has a lot of information. It is possible to distinguish between feeders and venous route depending signal value. Feeders is most highest signal and then shunted pouch, and then cavernous sinus. We can see cavernous sinus is a relatively lower signal, and artery and shunted pouch is very higher. But if shunt is shown in only unilateral angiogram, contrast of signal value is not remarkable. Here's the left ECG's source image of 3D DSA. We can see the arteries and the shunted pouches here, and cavernous sinus, and the other draining vein. After interpretation of these images, I could find 4 shunted pouches connect to intercavernous sinus. 1, 2, 3, 4. And the shunt will occlude to embolize these 4 pouches or with intercavernous sinus. And here's the schema of this cavernous sinus, this case. And here's the intercavernous sinus. And from right ECA and left ECA, 4 pouches. Intercavernous has 4 pouches. And the IPS is patent, and SPS and SMCV has a reflux. And we can embolize only intercavernous sinus via IPS. We embolize, we can cure this disease. And this strategy does not disturb to access the remaining veins. So if the embolization of intercavernous fail, we can embolize these outlet, and sinus packing can be done. So the strategy is safe. If we can, we embolize not only intercavernous sinus, but also left cavernous sinus. After that, we cannot access to SPS and SMCV. It's very dangerous, but only intercavernous packing is very safe. Intercavernous is here. Here is the very 8 speed, very fast image. And microguide warrior, we can here the AP view and the IPS and microcatheter advanced left cavernous sinus and left intercavernous sinus. Shunted pouch is here and here. I want to embolize most of this distal part. I embolize to back and backward. Very intercavernous and cavernous sinus had some very tortuous and septum. They have septum, but I success. And then distal access catheter also advanced to intercavernous sinus. This is very important to tight packing for intercavernous sinus. Here is the tip of microcatheter and the tip of distal access catheter. That tactics is a Japanese domestic catheter. The tip is 3.2 French and very cheap catheter, so I like this one. And embolize the first pouch one here, and a part of coils migrate to feeders. It's not so problem. And embolize the second pouch. It is hard to advance a microcatheter to pouch 3 and 4. So during the embolization of intercavernous sinus itself, headway 17 advanced to pouch 3 and 4. So I embolize them. Total 24 coils was put. After treatment, complete occlusion was achieved. And the retrograde flow of left SMCV returned to antegrade flow after treatment. Here's the complete occlusion. 6 months later, angiogram showed cavernous sinus is used for normal circulation. So it is not so important, but we can. It is good for patients to return to normal circulation. Next, 62 male superficial sinus dural AVF. Onset is right hand paralysis. At first, he was treated as cerebral infarction, but MR showed high intensity area in white matter. CT and DSL revealed SSS dural AVF. Here is right ECG AP view and left ECG. Both MMA gather to center, and the bilateral vein, bridging vein, is drainer. Here, the left ICAG, we can see ophthalmic artery and the falcian artery goes to affected sinus. And the posterior part of SSS is patent and use normal perfusion. Here, the ECG, MMA is prominent, but it's this angiogram does not opacify the affected sinus, but contralateral ECG opacify the isolated sinus here. So normal perfusion we use from here to here, but so SSS is divided to two segments, two parts. Here is the isolated sinus type dural AVF. Here the angular features summary. Feeder is bilateral MA and left falcian artery. The shunt is located in anterior part of SSS and the isolated sinus type. And the drainers is the bilateral bridging vein connecting to the mid part of SSS. Here is a good indication of Oncolytic TAE because easy to feel the affected sinus. Bilateral MMA are equal to contribute to shunt and to be less bending, so we can use both arteries. In this case, anyway, at first I attacked left side, and if a complete occlusion is achieved, treatment is done, but it failed. The second right side. We can embolize. Here, device 6 French shuttle sheaths I like for dural AVF treatment because a highly supportive system is required because it guides the microcatheter to peripheral blood vessel. Here is the first attack from left side. Unfortunately, MMA, I perforated the MMA here. Here's my guide wire and microcatheter, and the microcatheter perforates. And it shows MMA to MMV fistula. So I gave up to use this artery for treatment of dural AVF. I embolized this iatrogenic fistula using NBCA. Here is 33%. And this part and from proximal part, I injected. MMA is occluded. So remaining contralateral side is very, very important artery, and the right MMA can opacify the dural AVF, whole dural AVF after embolization of MMA. So we can see a good very good opacified. After navigation of a microcatheter, here the APV and the lateral view, here the SSS and the tip of microcatheter. I start to inject of Onyx 18. At first, Onyx migrate to SSS. After that, always Onyx does not advance. The tip of microcatheter reflux to microcatheter and take the 15 or 30 seconds, sometimes 50 seconds. Injection restarted. 3 or 5 times I took a pause. Yes. In this case, 30 minutes later, Onyx advanced to sinus and sinus packing started. During 3 or 5 times pause, made the strong plaque enough to strong plaque to inject the Onyx, advance the Onyx. Onyx advanced to posterior third part. Our aim is to fill bilateral bridging vein in addition to SSS. The purpose is to protect recurrence of DAVF. Now left side and the right side and the right side. Both sides, I can feel the Onyx. Onyx is very weak to thrombogenicity. This is different characteristics to NBCA. So we must packed sinus and reflux to vein. In the final view, complete obliteration was found. In this case, total amount of Onyx 18 is 0.992 milliliter. And here, this shape of Onyx gas is almost the same. This pre-embolizations sinus shape. Injection time is 33 minutes. In this case, 3 years later, the MRA showed no recurrence. Right hemiparesis disappeared soon, and there is no neurological deficit. Here, the transverse sinus drug AVF, Borden type 1, 72-year-old male. Here, the left ECG lateral view, arterial phase. Feeder is the left MMA, and the DAVF is here. And the IJV is patent, and the cortical vein reflux is absent. Here is the AP view. Left transverse sinus shunt flow drain to both sides. Left OA and pica and PCA contribute to DAVF. Transverse sinus DAVF is difficult to detect shunted pouch in most cases to perform selective embolization. In this case, flow of all cortical vein is integrated to sinus. So sinus occlusion is dangerous, so we chose Onyx TA. The purpose is diminished of tinnitus. To embolize the arterial network along dura mater efficiently, we use balloon catheter in transverse sinus. Here, the Japanese balloon catheter shown is 7 mm by 7 mm, but it's smaller than sinus. But in Japan, large caliber balloon, soft balloon catheter is not available. So we use this balloon. After 2 milliliter injection, direct to 12 millimeter by 30 millimeter. Here I showed you. Under sinus protection, Onyx TA was done from MMA and inject, and the Onyx distribute to surround the sinus, but yes, and here and attach the balloon Onyx reflect to another arterial network surrounding this balloon. Not only, this arterial network, embrace this arterial network, I think to have an effect to prevent the recurrence of shunt. Very many arterial network was embraced. Here's final view, and here's the final view. Complete obliteration was achieved, and left transverse sinus is patent, but flow of temporal vein became slow. And post-operative MRI showed venous high intensity. It means, I think, venous congestion of left temporal lobe. And fortunately, no neurological symptom occurred, and the tinnitus disappeared. Case series of Onyx TA with sinus balloon protection, 6 reports was seen. Pishoriak reported occlusion vein of Labbe, 1 of 9 cases. So venous occlusion is very, we must take care of this complication. Originally, the purpose of sinus balloon is 2 purposes. Sinus protection balloon has 2 purposes. Balloon inflates free in the sinus to minimize the risk of onyx migration to sinus and to seal the orifice of cortical vein. But in our case, onyx actually migrates to the cortical vein. Here. And it may be easier to prevent obstruction of cortical veins by creating a small gap between the balloon and the sinus wall. Sinus balloon is not fully open. Just sinus circulation is patent. Yes. Yeah. If onyx come to sinus, we must stop to inject. Arterial network does not embrace, but it's safe to obliteration of the cortical vein. Yes. So it's a very key point to prevent obstruction of cortical vein. Sinus balloon is too much inflation of sinus balloon is not so safe, I think. Here's very important. Here, the left SPS dual AVF case, a unique case, incidentally found, and she has headache. And he has shunted, he has very high intensity area, large pouch. And here the ECG, AP view, and lateral view. Here's a large pouch here. In lateral view, we can see many vessel. Feeder is MMA, petroidal branch, and accessory meningeal artery. And here's the shunted area. And the draining vein, petroidal vein, and the lateral mesencephalic vein, and the basal vein of Rosenthal. Here the ICG in lateral view. Meningohypophyseal trunk is here, and the central artery goes to here. In venous phase, SPS was not opacified, and the normal perfusion used the basal vein of Galen fissure. Here the left VAG, venous phase, no venous congestion, and the SPS was not opacified. Here the 3D DSA of ICA. We can see the feeders and the drainers and shunted pouches here and drain to petroidal vein. The original petroidal vein make the varix in schema here. Here's source image of 3D DSA, varix is here, and shunted pouches here. Small tiny arteries gather to shunted pouch, and then drain to varix, we can see. Here is 3D FFET1 gadolinium enhanced MRI. Both thrombosis and vessel reveal high intensity signal is here. Next, 3D TSE space T1 and gadolinium enhanced and fat suppression. In this image, vessel lumen with normal flow is not opacified. Like this, here, ICA is black. But SPS was opacified. It meant that the flow of SPS is stagnant with severe stenosis. We can see severe stenosis of SPS. And so we can advance via SPS to shunted pouch. Access via contralateral IJV, we do. Beyond the conference, 3.4 tactics here, and headway is here. The French shuttle sheath is here. Headway 17 did not advance SPS, is here. Tip of microcatheter, and here is micro or supersective angiogram from microcatheter. Tip of microcatheter is here, and here's the stenosis point. In the, here, the duct is backward. Here's very difficult to advance the microcatheter. In this case, I advance microguide wire, and the firm point come here. So we at that I succeed to advance the microcatheter. Use a firm area of guiding catheter. Tip is soft and base is firm. After that, we took the 3D angiogram. We can see the tip of microcatheter inside the varix, and across the shunted area, and the tip of microcatheter is here in the varix. So we embolize the varix and then shunted pouch, and then FPS was also occluded. Complete obliteration was achieved. Here, the post-operative MRI, we can see the coil mass artifact here, and she discharged and without complication. And today's summary is here. TV of cavernous sinus dural AVF is safe method, especially selected embolization of shunted pouch can avoid cranial nephropathy due to mass effect and cardiac complication due to DMSO. Onyx TAE of dural AVF with isolated sinus is currently a basic treatment. TV is still an effective treatment for dural AVF, where Onyx TAE is difficult. In conclusion, although dural AVF is difficult to recognize the angular architecture, knowledge of vascular anatomy and the interpretation ability of image are reflected in the treatment results. How to deliver the embolic material to the shunted pouch or affected sinus is the key to successful treatment. Thank you for attention.
Thank you, Professor Izumi. That was a very nicely illustrated talk. I think you have shown some very good cases. We in India, we see a lot of venous sinus thrombosis. As a result, when the sinus recanalizes or for whatever reason, we see a lot of patients who come with dural venous, arteriovenous fistulae or AVM, if you want to call it. And we have huge numbers. I mean, I've treated more than 1,000 of these now. And the presentation is very different. When it is an extensive sinus involvement, most of these patients come with raised intracranial pressure. They come with sometimes loss of vision, blindness because of bilateral papilledema. In fact, that is a very, let's say, not an uncommon presentation that we have seen. Hemorrhages. Hemorrhage is another very common presentation. And the hemorrhage is almost always when there is a massive cortical venous reflux. Sometimes there is a direct reflux into a cortical vein from the sinus. Those are the most dangerous. So at least I insist with all my fellows that if you see venous reflux, which is early, then treat early, because many of these patients come with hemorrhage. And you sometimes see large venous pouches along the draining veins. And as you have rightly pointed out, what is most important is to locate the site of the fistula, which you said where the vein expands, becomes bigger, artery is small, vein is big. So that point you have to find and be very careful to get that. The other thing that we always look at is what is the competition between the venous outflow of the brain and the venous outflow of the fistula. So in your patient where you had that venous infarct, the vein of Labbé was draining. So when we are looking at an angiogram, very carefully we look at where is that vein draining. And if that vein is draining into the part that you are going to occlude, you have to be careful. But I feel that if we give low molecular weight heparin, if we have got the whole fistula and it was a high flow fistula, every time we have treated a fistula, we have closed the fistula, we give the patient low molecular weight heparin because there is a progressive stagnation and thrombosis of the venous side. So many of these patients come with venous infarct, even if there is no venous reflux. So every patient that we treat with a dural, whether it's a cavernous fistula, whether it's a cavernous sinus fistula, transverse sinus fistula, but when there is a high flow venous reflux, we always give the patient full dose, low molecular weight heparin for about 5 days, twice daily for 5 days. So in your patient, perhaps, if you had given low molecular weight heparin, perhaps, I mean, I don't know, but I don't know whether it's a practice to give low molecular weight heparin in these patients, but we do. And you showed that very nice balloon that you have used. we luckily have access to materials more easily than you do. Your Japanese FDA is very strong, and every item has to be approved. And in Japan, it's not easy to get anything approved. Luckily for us, we have balloons which are available. So the Bolt balloon, what's the name of that balloon? That's a long balloon, 8 by 80, 8 mm by 80 mm diameter, or 10 mm by 80 mm diameter. And we have sometimes even used the microvention balloon. So those are very nice balloons, and we can deploy them to. But when we use a balloon, my worry is that the reflux of the onyx from the artery, from the vein, from the sinus to the artery. Sometimes it travels in the vein and then it goes into the artery. And if there is a tentorial artery, there are many reports that the onyx travels from the sinus into the tentorial artery all the way to the carotid. And patients have come with the infarct. So especially this is more common when you use a balloon, because now the onyx gets directed more towards all the feeders. So that is one worry that I have whenever I'm using a balloon, that I tell my fellows and whoever is there with me in the room, please keep an eye on the tentorial artery to make sure, or if there is a vertebral artery which is feeding, to make sure that it is not going into the vertebral artery. And so that's all I have to say. And if there are any questions from the house, they are welcome.
Thank you very much, Professor Izumi and Professor Karapurkar, for those wonderful comments. If there are any questions, this is my co-host, Dr. Liubun Singh.
Thank you, Raja. Thank you, Professor Izumi, for a very nice presentation. I wish to ask you regarding in which case that you have presented that you think that is most likely amendable by surgical means, not embolization. What are cases that you think can be treated with surgery? And if we're going to do a surgical treatment, which case that you think that CTA will be sufficient without a DSA? My last question is, Prof, in case that asymptomatic, like you show in 72-year-olds with tinnitus, Borden type 1, so in what case that we can wait and see without any treatment? And if we're going to wait and see, what are the imaging series that we want to do, the interval, and whether it's enough to do MRA or we need to do a DSA? Thank you, Professor.
And the first question, you have three questions. Okay, and the what is the first question?
Yeah. What case that you think that is suitable for surgical treatment rather than embolization?
And cranial cervical dural arteriovenous fistula is very dangerous to embolize. I think I prefer to do surgery. Okay. And some temporal dural AVF is also difficult and dangerous to embolize. So I prefer surgery. Okay. Remaining dural AVF is embolization is first choice.
Okay.
May I add something here? Cribriform plate dural AV fistula can sometimes be difficult for endovascular treatment. Cribriform plate. And most of these patients present with hemorrhage. Most of these patients present with a big hematoma in the frontal brain. So those can be treated by surgery. Where there is a cortical venous reflux, dura to cortical vein, those are very easy for surgery. But the patients who presented with the transverse sinus, there you have to excise the whole transverse sinus. So it can be done surgically, but it is a formidable operation because you have got a whole lot of bleeding from the scalp. You have got a whole lot of bleeding from the bone. There is a lot of bleeding from the dura. I can tell you this because I have operated on these in the 80s and 90s. We were operating because at that time we were not doing embolization. But today I would not operate on them. Today I would go for all by the endovascular route, except the cribriform plate. The cribriform plate. Sorry, please go ahead.
And the second, what is the second question?
Yeah, if the case that you want to do surgical treatment, say if only single feeder will CTA be sufficient, or we still need to have a DSA for the treatment?
CTA or DSA, you mean?
Yes, yeah. Just doing a CTA is sufficient for us to treat surgically.
I think 3D DSA is better to understand in detail and architecture in detail. So the surgeon, I'm not now. I'm not surgeon, just only neuro and vascular treatment, but vascular surgeon want to do angiogram 3D DSA,
Okay.
very tiny angio architecture. We can provide him.
Okay.
And the third is
what
type 1
in modern type 1, what case that we can wait and see, and if we decided to wait and see, what are the interval for the imaging, whether we need to do MRA for the follow-up or a CT DSA, and what's the time duration?
Usually I in follow-up I do MRA. In Japan, MRA is very available. So, and 1 or 2 year follow-up, I finished the MRI follow-up. Especially this patient hope to follow up MRI follow-up. So usually 1 or 2 years.
Okay. Thank you, Professor.
May I add something?
Yes, please.
So I think we should do a DSA at least once in every patient, because basically you want to see what is the venous outflow. If the venous outflow, even in the patient who presented with tinnitus, there is such a high venous reflux into the opposite transverse sinus that it means that there is going to be raised intracranial pressure. So if you wait, almost certainly that patient will come back with papilledema. Just now the patient has come with tinnitus, but the patient will come back. So I was telling you, we see a lot of patients with raised intracranial pressure. All of them are like that. So such a patient I would treat, I would not wait. If it is pure tinnitus, pure downward flow, no retrograde flow, that is the kind of patient I would follow up. If you see cortical venous reflux early, you have to treat early. That is the other thing. Don't wait. Sometimes, of course, you have got this whole sinus filling and then reflux into the vein. That is not dangerous. But from the sinus, supposing it's at the tentorial edge, it is going into the vein of Galen. Vein of Galen, many of these ruptures. So those treat early. And follow up, I think CTA or MRA is good enough, but try and do the 4D MRA or CTA, where you follow on time also, then you can see the venous reflux also very well. So as soon as you start seeing venous reflux, you should treat.
Right. Thank you. Thank you very much. I think we had a very wonderful session, and now it's time to wind it up. May we kindly request Professor Karapurkar sir's final concluding remarks?
At least our experience has been that, like I told you earlier, difficult to diagnose. But once the diagnosis is made, today we have such wonderful tools that we can go at it by the arterial route, we can go at it by the venous route, we can use coils, we can use glue, we can use onyx. And what is astonishing is even patients who come in unconscious, who come in paralyzed, recover fully and are completely functional. So we have wonderful results today, and we have wonderful tools today, and we should exploit, as Professor Izumi has shown, the full angiography and study the angio architecture very carefully. That is the key. Study the angio architecture very carefully. Thank you very much. There has been a wonderful presentation. Thank you so much.
Thank you. Thank you very much. May I kindly invite concluding remarks from our first chair, Professor Jian Hongzhu also. Any concluding remarks, Professor, from your side?
Thank you very much.
I'll wind this up officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Gato. I would like to sincerely thank both the speakers, Professor Kazuhiko Kurozomi and Professor Takashi Izumi, as well as the honorable chairs, Professor Jiang Hongzhu and Professor Anil Karapurkar, for coming here and supporting the educational initiatives of the ACNS. Thank you, Dr. Liu Boon Singh, my co-host for today. So thank you, everybody, and all the distinguished guests who joined us. Until we meet on the 5th of May, it is bye-bye from all of us. Thank you very much for joining.